Good morning, ladies and gentlemen. My name is Saïde Frias. I'm the head of the Human Medicines Evaluation Division, and I'm truly delighted on behalf of the EMA to welcome you to London, with an emphasis on London and specifically to this workshop on the chronic non-infectious liver diseases. All of you, whether representing patients or healthcare professionals, academics or regulators, are joining us from across the European Union, some of you even globally, to share with us your truly experience and expertise on this specific challenging topic. A debate that will be further enriched also by industry presence to give the perspective from those researching and developing medicinal products that are so much needed. Let me express my sincere thanks to the EMA Working Party Secretariat as well as the Scientific Organizing Committee to deliver such a great draft agenda as well as a lineup for this workshop. A workshop that is designed to share and discuss the state of the art on three non-infectious liver diseases, two of which are orphan diseases, the primary biliary cholangitis and the primary sclerosing cholangitis, as well as NASH, the non-alcoholic steatohepatitis, all of which have a significant negative impact on public health to date. It's the slow progression of these diseases and their unspecific symptoms in the early stages that make these clinical trials so challenging and thus represent even to date a disease area where there are very limited treatment options available. So what is required is an interdisciplinary approach to discussing trial design, suitable endpoints, as well as suitable study populations, and that's precisely what's on the agenda for the program today. There is therefore no doubt that this meeting will bring valuable insights into the finalization of the EMA reflection paper on the drug development in this area, and I very much look forward to hearing your inputs and actual outcomes of this workshop, and wish you a most enjoyable day in achieving this objective. Thank you very much. With this, I would like to hand over to my colleague Joachim Musaus. Joachim, please.
Yeah, also a very warm welcome from my side. My name is Joachim Musaus. I'm here in charge of gastroenterology in the Scientific and Regulatory Department of the EMA, and we worked together with the drafting group on this reflection paper draft. Let me start with some housekeeping rules. The meeting is broadcasted and recorded, therefore please get close when you speak to the microphone and switch it off when you are stopped speaking to avoid any interferences. And then you will have recognized that there are different colors of badges here. There are gray, black, blue, and red ones. And this connects to, to the level of security or the level how you can move in these buildings. Me, for example, I'm from the EMA, I have a blue badge, and then this comes to be relevant if you have a red badge, because red badge holders can enter here, this room and this floor, but when you are going out for having lunch, you can unfortunately not enter the canteen. When you go out and you come back for lunch, please be 10 minutes before we restart back. Then you will get picked up at the entry. Go to the lounge in the ground floor, and there you will be picked up. The gray and the black badge holders are allowed to move in the building to go to the canteen, and there was description in the email. You can purchase a card if you want, which you get reimbursed when you give it back after lunch. But you're of course also free to go out for lunch and then coming back. So you don't need to get picked up. You can go straight away here to floor 3 to restart after lunch. Okay, also thank you very much to everybody joining. There will also be people joining via Adobe or follow the external broadcast. The FDA will join a bit later, I suppose, because they are not yet still out of their beds. And yeah, finally, I want to thank very much to Monica, who did the biggest part of the organization, and please give her a big clap for that. So not to delay, because we have a challenging program, as I said. I asked for the first two chairs, which is Dr. Elmer Schabel from the German Medicines Agency and Marie Thoern from the Swedish Medicines Agency, who chair the first meeting. The speeches will be held from your place. And we will not do a tour de table because we are about 70-80 people here in the room, but what I would like to have is just to have introduced the first row of the people who are sitting here in front of you. Maybe we start from this side.
Hello, my name is Chrissy Palidis. I'm a pediatric coordinator here at the EMA, and I deal with the pediatric investigation plans on liver diseases and gastroenterology. Thank you.
And my name is Mark Ainsworth. I'm from the Danish Medicines Agency, and I'm head of the gastroenterology drafting group.
Good morning, I'm Richard Vesely. I'm head of rheumatology, immunology, gastroenterology, and respiratory office here in the agency.
Yeah, my name is Elmer Schabel from the German agency, member of scientific advice and the drafting group who prepared this paper. Yeah.
Good morning. My name is Marie Thoern, and I'm from the Swedish agency, and I am a gastroenterologist, hepatologist by training, and a clinical assessor at the MPA. Thank you.
Good morning. My name is Peter Sitani. I'm pediatric gastroenterologist, member of pediatric committee of EMA and gastroenterology drafting group.
Monteminio, a pediatric gastroenterologist, and I'm a member of the pediatric committee at EMA.
Okay, well, again, a very warm welcome to everybody from my side. Maybe before we start with the presentations, a few introductory words about the reflection paper, why it was only a reflection paper, and where it's going to be in the future, and what will be the fate of this paper. Many of you might already know from the context of the Liver Forum or the PSC Forum that we were planning to draft this paper. The usual procedure normally is that we have the stakeholder meeting first, and then put up the draft for public comments, and then finalize the end version of such a paper. Now, Brexit has torn this a little bit apart already, because we finally decided to have the drafting of the paper first and then do the stakeholder meeting. Then the stakeholder meeting was also for a long time not so clear that we could still hold it in London, or whether we have to wait for the move to Amsterdam. But we're very thankful that we have finally placed this at the end of this year to be held in London. And as you all know, also the reflection paper is now out for public comments, I think until August next year, which is rather a long time, of course, but this is also in the aftermath of Brexit and the move of the agency. Things have to settle first until the work can be taken up at full speed again. So you all and other stakeholders, of course, which have not the opportunity to be here, have the chance to comment on the paper, send written comments until mid of next year, or August in this case. And then we have to finally make up our minds and draft the final reflection paper. Now, the paper itself, it has already statements in it that this may be a preliminary guidance paper only. It has got to do that, of course, the regulatory experiences with licensing procedure is limited at this moment. There is the Ocaliva case, which we will be hearing in a couple of minutes about, but nothing else in all the three diseases that has come across. So It might well be the case that if relevant licensing procedures come up in the future and there is experience in the regulatory field with all these kind of problems that we tackle today, that the reflection paper will be superseded by final guidance documents. And it is not unlikely, at least in my mind, that we will have to separate the diseases, at least separated in two. The two orphans deal with in a separate paper, and the more common disease NASH also in a separate guideline. But this is for the future. It will, for the moment, at least for the finalization in the end of 2019 or beginning of 2020, remain a reflection paper, because I think still at this time point the number of procedures that we deal with will be very limited, if not unchanged from now on. So this is how it stands. And with these introductory words, I think we should go into the presentations. We have in PBC, which is the first topic, a couple of presentations, 5 altogether, which are meant to set the scenes for the following discussion. Maybe we should speed up the process, because we have only 60 minutes to discuss the whole field at the end of the presentations. We will only allow maybe 1 or 2 questions at the end of the presentations if needed. Otherwise, the discussion will be postponed to the end of all the presentations that we have. And with this, I will call Robert Mitchell-Thain to give us the first presentation about the patient perspective in primary biliary cholangitis.
Okay.
Please.
Good morning, and thank you. So, ladies and gentlemen, I would firstly like to thank you for the opportunity to speak on behalf of the patients and express their perspective. I'd like to congratulate you on the draft paper, which I think is a great start. And I would also like to apologise for Brexit. So, those out the way. So very quickly about the foundation itself. We are UK-based. Amsterdam sounds nice. We have over 13,000 patients registered from 76 countries around the world. At the moment, we have 19 languages on our website, and our new app on self-management will be coming out in 9 languages. So just to let you know that we are truly international. Now, in terms of the patient voice, what we have done is we have looked at our volunteer network, who are our first local points of contact with PBC patients, who help a conduit to two-way conversation between the foundation and patients. We have surveys, which our registered service users will input and feed us their feedback to let us know what they're thinking, what they want, what they need. Face-to-face consultations, and of course helpline calls. So these are the kind of services that we use to ask our patients for what it is that they need and look for, and use that to feed our decision-making processes. So, patient priorities. So we thought the first place to start was with Urso deoxycholic acid. It's good, but is it good enough? And the answer is no. As long as there are patients still needing transplant, then it's still not the answer. In terms of Urso, it still does nothing for symptom management, even though we do have occasional patients that are prescribed Urso for their itch, and even the more occasional patients that are prescribed Urso for their fatigue, but we can talk about that in a whole separate event. In terms of patient priorities in Urso, we do know that there are patients who are at risk. We know that age, sex, time of diagnosis in their PBC journey do have an impact on Urso response, so we need to look at that. And I think that it would be good to look at the potential of the high-risk patients being open up to possibilities before they have a year of failure with Urso deoxycholic acid. And the other thing that comes from that is that we still have this 12-month wait for response confirmation. And the question is that really relevant? Can it be done in 6 months? Do we have to wait at all if we really, truly appreciate that the patient is a high-risk patient? So in terms of patient priorities and histology, So the first myth to get over is this idea of patients having stage 2 PBC. So stage 2 histology is one thing, but we need to break away from describing PBC patients as their histological stage. So in terms of trials and moving forward, it's absolutely important to us that histology is not compulsory. Patients tell us time and again that they do not want to do biopsies that are not entirely necessary, but I will go into slightly more detail about that later. However, if histology is to be measured, what the patients were looking for is, again, a bigger picture view, looking towards the future and trying to change the way that not just PBC, but the other conditions are investigated and explored as well. So the patients would be looking for a side-by-side validatory study to look at other forms of histological staging to be used alongside biopsy, so that you're looking at maybe an MRI or some of the other technologies that are available that have still not been validated for PBC. So if histology is to be incorporated, we would be hoping that there is some kind of study to look at that and incorporate it. So in terms of the patient priorities and the unmet need, so biggest single gap at the moment is the AIH overlap syndrome. For original trials, for example, the original start of the OCA trials, the AIH and overlap was an exclusion criteria. And yet these are patients that still have enormous difficulty, enormous unmet needs. So it's about how do we address that, how do we include them in options in the future, and how do we take things forward for this particular small but challenged population. Ultimately, the cure is the biggest drive for patients. Thereafter, obviously, we're looking at symptom management. And when we talk about symptom management, the biggest single one in terms of quality of life is itch. And if we are still looking to transplant people because of itch, if we are still losing people who are committing suicide because of itch, which still happens at 2018, then we have a huge unmet need that we need to address. And the last priority in terms of unmet need is also dealing with fatigue. How do we address this within the population in terms of clinical trials and moving forward with medications? The last part I'd like to talk about is patient priorities taking part. So we asked survey which came in at 1,089 patients in a 2017 survey. One of the questions we asked are what would be the obstacles to you taking part? Now this was a free text box, but what we did was we collected the answers, and the first thing that came up is that travel and access to the actual centres themselves came in at 10% and was one of the biggest obstacles to taking part. So please take note of this. Now patients will tell us time and again that biopsy is an issue. They don't want unnecessary biopsies. However, and it chokes me to say this, that in terms of biopsy being an obstacle, that only 1% of patients said that this was the case. So take that from what you will. The incentives, again, it's really, really clear that patients want to take part if they feel that there's a potential cure on the table, and also if they are looking at symptoms and symptom management, that is a huge incentive to be part of the clinical trials and to look at the bigger picture. With PBC, you have an informed, engaged population who want to make a difference, not only for themselves and their own generation, but for the generations that follow. And on that note, I thank you very much for your attention.
Well, thank you very much. I wonder if there are any short questions to Robert. So you think the biopsy discussion today maybe is one of the most interesting one, and for the patient perspective?
It comes up, it's an issue,
yeah,
absolutely.
It's an issue.
We would like to see, in an ideal world, no biopsy, so it would be ideal to try and move away from biopsy for clinical trials.
Yeah.
And if we can find a way to do that, I think that patients, not only in PBC, but with other liver diseases, would be better off.
Yeah. Okay, thank you.
Thank
Was
you.
it someone else? Just a short question.
Yes. Well, actually, I was a bit amazed by the 1%, because within PSC patients, we did a various surveys, and the percentage is much higher. Just wanted to add that.
Yeah, okay. Okay, well, one more question, then we move on.
And just add, I think what the situation, so I'm Martine Wormsley, I'm representing PSC patients, and I think we don't like biopsies, but the fact that Robert showed only 1% saw it as a barrier to research is not really about biopsies, that's about the appetite and desire for a treatment and what people are prepared to go through, but nobody's saying they want biopsies.
No. Of course. Okay, thank you very much. And then it's Joachim Musaus that will present the authorization of Ocaliva, please.
Just shortly to back to the housekeeping rules. I forgot, please say your name and affiliation when you are speaking, because people are following the broadcast might not see your name on the plate. So, yeah, my task today is to speak about the authorization of Ocaliva and the ongoing issues. I don't think that I will provide you guys with any new data. I think you are very well aware of these trials. It is rather to give you a picture on how we do our regulatory assessment and how we did it in the case of Ocaliva, which was a quite challenging one in terms of let's say, to bring it in the regulatory context and to make it available to the patient. Well, this you will probably expect. I have nothing to declare. And also, as I'm EMA staff, but I'm not speaking with the voice of the EMA, so all what I say is to be taken as my own opinion. So Ocaliva was got a positive opinion by our scientific committee in October 2016 for a conditional approval because it was considered to address an unmet medical need, and the benefit of immediate availability outweighs the risk from less comprehensive data than normally required. There are a lot of regulatory terms in this presentation, and I will explain them when wherever possible. If not, please ask a question at the end of the presentation. In the framework of this conditional marketing authorization, the marketing authorization holder needs to complete specific obligation to reconfirm that the risk balance is positive, and also as it is a conditional approval, you need the drug is subject to additional monitoring, safety monitoring. In December 2016, this is a normal process. The European Commission granted marketing authorization throughout the member states based on the CHMP's scientific positive opinion. What did we see at the approval stage? We see obviously we've seen an application on PBC, and we've seen the picture in the landscape of the approved drugs. It was at this stage, at this time, ursodeoxycholic acid as the only authorized therapy and considered first line by EASL guidelines and AASLD guidelines. Mainly because it improves biochemical indices and it delays histological progression. And there's also strong evidence, or there was strong evidence, and it still is, that the increases in progression-free survival are greater for patients who demonstrate a greater response on ALP, bilirubin, and ALT. To the unmet medical need, we knew that about 50% of the patients fail to respond or have a suboptimal biochemical response or are intolerant to UDCA, and that these 50% of patients have a higher chance to progress in the disease. So an unmet medical need is given. There was one single pivotal study submitted. This is also regulatory terms. We normally require replicate replicate trials. This is a level of evidence we usually required, but under certain conditions we can accept a single pivotal study. And the primary endpoint, you are well aware, was an ALP reduction below 1.67 ULN, and together with at least 15% decrease, and normalized bilirubin for the OCA 10 milligram group. The primary endpoint was reached. The key secondary endpoint on the titration group was also reached with high significance. Importantly, what we saw in the dossier was that the change from baseline was also seen after 6 and 12 months on other important laboratory parameters that are as outlined on the slide. And also very important, we saw that about 1/3 of the OCA treatment group achieved ALP reduction of over 40% compared to 1% in the placebo group. And this is how the efficacy is outlined or summarized in our public assessment report, and there we come to the uncertainties, because the submitted data was mainly based on laboratory response. And few patients achieved normalization of ALP, so for us it was a challenging task to consider or to put in the benefit risk to what extent the laboratory parameters actually correlated with the clinical liver outcomes, because we didn't have the correlation yet. We were submitted data to increase this evidence based on the global PBC study group and the UK PBC cohort, where the company applied the inclusion criteria as well as the primary endpoint on this cohort. So we had some supporting evidence, but indirect evidence. Then, is the patient population enrolled in the pivotal trial sufficiently representative for the label? It's another question we had to deal with, because the included patients most of the included patients were in a not very advanced disease stage, and had, for example, had all a bilirubin below 2 times ULN. So how do we look at the patient population? And we had quite limited long-term data at this stage, up to 30 weeks for a limited set of patients. Coming to safety, as you all know, the most common adverse reaction was pruritus, but it tended to resolve with continued dosing, and very few patients discontinued due to the pruritus. There were another issue we discussed on the hepatic-related effects, which seemed to be dose-dependent. And so this was addressed then in the SMPC, in the dosing recommendation, to make this dependent on the stage of the disease, and to taper it down when the patient progresses, that you have the same exposure, or more or less the same exposure in progressing patients. So to look at the uncertainties of efficacy, of safety, the representation of patients with more advanced disease was scarce in terms of efficacy, and also in terms of safety. So we would like to see more data on this. And there was an issue on HDL level reduction and LDL increase, so we asked for clarification on the cardiovascular risk of the drug. This is the summary of safety concerns from the risk management plan, where you see a bit more in detail than what I said, how the risk was characterized, or the risks were characterized, and where the missing information is. Sorry. And out of this, at the end of the procedure, we had to build a balance of the benefit and risks. And to summarize that, we have a serious, severely debilitating disease. We have a clear unmet medical need, up to 50% of the patients not responding satisfactorily or are unable to tolerate. And OCA demonstrated relevant ALP reductions, which are reasonably likely to translate into benefits in terms of a clinical outcome based on the submitted data. And this against the safety profile, which was considered to be manageable, or is considered to be manageable, came to a positive benefit risk in terms of a conditional marketing authorization. There we come back to the beginning. In a conditional marketing authorization, the benefit risk needs to be reconfirmed, and based on well, in general, in the conditional marketing authorization, the marketing authorization holder has to submit fully comprehensive data to confirm. And this on the efficacy and safety, on the long term, and in particular in advanced liver disease stages. So to summarize again, the product receives a positive opinion because the benefit-risk balance is positive. The benefit outweighed the risk. The unmet medical need is considered to be met, and the benefit of public health of immediate availability outweighs the risk for still need of further data. And also important is considered sufficiently likely that the applicant will be able to provide comprehensive data post-authorization. Sorry. How can we go back to the last slide? That's very... And these are the open issues or the studies which are currently ongoing, which we are requiring in the framework of conditional marketing authorization. The first study on clinical outcomes, probably the most important of the two, and the second related to patients with more advanced liver disease. So safety and efficacy data on clinical outcomes. Thank you very much.
Thank you, Joachim. Are there any burning issues with this presentation? Maybe a remark from my side. You have seen that studies are ongoing, placebo-controlled studies, to prove an effect on, let's say, the hard outcomes. Whether such is a way forward in future licensing procedures and for further compounds to come up is a big question, of course, that we have to reflect potentially also today. To me, this appears questionable once efficacy of Ocaliva has been established for second line. Then there is a standard treatment, and to keep patients then long-term on the placebo will be much more challenging than it has been for Ocaliva. Even they, of course, face the challenging situation that their compound is, of course, freely available to everybody in the countries where it is marketed. And still patients are in the placebo-controlled trial here. So we hopefully see the comprehensive data that we all desire, but this is, of course, burdened with some uncertainty. Okay, as there are no immediate issues with this talk of Joachim, we would move forward then. Gideon Hirschfield from Toronto General Hospital in Canada is giving us a presentation about definition, natural history, and current therapeutic interventions. Gideon, thank you.
Okay, well, thank you very much. Let me just, oops. There we go. Very concise. So it's a pleasure to be here today. So obviously I'm here speaking on behalf of my program in Toronto, but my prior program in Birmingham, and some of the work that we did with Quentin and Greaves for the MHRA in helping you with your stakeholder document. So what you've asked me to talk about is PBC and to understand a bit about how we're managing it at present. My disclosures, I work very closely with my patients, with academics and with industry, because I think we all have a shared goal that we want new drugs for all of the diseases we're talking about today. These diseases, from an autoimmune perspective, are very much related, and we try and learn from each other. And just as a note of optimism, I think it's fantastic for us to be here talking about PBC, where we have managed to get a new drug licensed using very complex and up-to-date regulatory approaches, because this does give us a lot of hope for autoimmune hepatitis and also, of course, for primary sclerosing cholangitis, where essentially we are duty-bound for our patients to be innovative in our approaches to proving the efficacy of interventions. These diseases are rare. This is UK data based on primary care practices, over 1,000 practices. And you can see that the incidence for PBC, for example, is just over 2 per 100,000. If you compare that to type 2 diabetes, it's 400 per 100,000. So these are common rare diseases, but that adds to the challenge. And for when we talk about PSC later on, you can see the incidence is half as much as it is for PBC. So the challenge is the rarity as well as the impact. The disease themselves, when we think about PBC, really our patients live in a cycle. They live in a cycle of 3 components, which in many respects are represented by some of the blood tests we'll talk about a lot today. Immunity inflammation, so in a sense we see that with elevations in ALT, AST. Cholestasis, we see that with elevations in alkaline phosphatase and in gamma-GT. And fibrosis, we see that with a falling platelet count. And our patients are in a cycle of injury that is persistent and which we hope our therapies, current and future, will alter. And of course, how our patients present is not the same as how they are 5, 10, 20 years later. So our therapies may need to be tailored as to the course of the patient in front of us. To summarize the biology, it is worth just reflecting a little bit on the biology. It is complex. It is both autoimmune, but for PBC, it is also very, very much biliary. It's a cholestatic injury. The immune component attacks the biliary epithelium. The biliary epithelium responds. That response in itself is pro-inflammatory and destructive. And then the loss of bile ducts, the holes in the bile ducts that are occurring in the biliary tree, leads to the cholestasis. And cholestasis itself is profoundly pro-inflammatory and pro-fibrotic. There are additional features, and you've already touched upon one of them, which is the lipid abnormalities, and this was actually just a very good example that this is a live issue in 2018. This is a patient from this year who presents with profound xanthelasma because they got such profound cholestatic ductopenic liver injury. So for PBC, we are relatively easy in terms of diagnosis. This helps us in terms of inclusion criteria for clinical trials. We're able confidently to manage our patients without histology from a standard of care perspective, but that doesn't answer the question around the role of histology in clinical trials, which is a very distinct question. But in essence, we can be very confident that a patient who enters a clinical trial has PBC so long as they have a combination of cholestasis and anti-mitochondrial antibodies or some other specific anti-nuclear antibodies. There are a group of patients who don't have all of those features and for whom those patients would normally be required to have liver biopsy confirming PBC. The take-home, however, is because of this, we're able now to diagnose our patients readily. We're diagnosing our patients at an earlier stage compared to prior experience, and that's how we know that 1 in 1,000 women over the age of 40 live with PBC. This is just to summarize one of the challenges that we have, but also one of the utilities from using surrogates, is that we have a number of approaches that we use both to diagnose and, which I think Bettina will go on to talk about later on, to offer prognosis and to predict outcome for our patients. And so we are in the unusual situation where we use our tests that we use are reused in a sense, both for diagnosis, risk stratification, and for treatment efficacy. We're not using all of these tests yet, and maybe some of these tests could one day improve what we're doing. And the example I would give, for example, is we don't yet use, for example, immunoserology particularly efficiently, because that also identifies a subgroup of patients who have a poorer prognosis. So one of the things that has the PBC community has benefited from is by the fact of now having 2 licensed therapies has been a big emphasis to improve the standard of care all round for patients with PBC. So it's a further surrogate benefit of new drug discovery is that standards of patient care rise because of care pathways. So this just now tells you our current care pathway for PBC. We diagnose patients, we make sure the diagnosis is secure, and with confirmed diagnosis of PBC, we'll move on to treat our patients. The question then arises, what is the natural history of PBC? And this is a very difficult question to answer in 2018. The natural history is defined as the untreated history of a disease. And that data is historic when we look at it in the literature. That data is centre biased. Historically, all the studies that came out on PBC were from centres with a particular interest in PBC, and therefore the demography of those patients is not necessarily representative. We've learnt that from our big cohort studies. We've learnt that when you pull the data from many, many centres, you get more information. However, a very good example of the natural history, so to speak, goes back to Martin Prince's study when he was working in Newcastle. And you can see here from this Newcastle cohort where the average age was 61, slightly higher. Remember that the Newcastle physician was a the elderly physician who did a lot of the work on PBC. But the median survival then was 9.3 years. So in that cohort, going back, clearly we can show the impact of this disease when presenting at late stage. But these kind of data don't take into account risk and are not stratified for treatment response. When we do go back again through some of the other literature, we see that, yes, this kind of overall picture of the natural history of PBC is true for those days. The average survival was 9 to 10 years. In the absence of effective therapy, the median time to develop extensive liver fibrosis is approximately 2 years. A lot of the data comes from the Mayo Clinic. The Mayo Clinic is also not an unbiased centre when publishing on PBC. It's a referral centre for the entire United States. But you can see that the early studies at the rate of progression to cirrhosis over a follow-up period of 6 years were around 50% of patients either receiving a drug that didn't work or placebo. And that there was then evidence from the UDCA treatment that reduced the progression to cirrhosis. Okay, and then there's similar data from Paris indicating a 5-fold lower annual progression rate once you start to use ursodeoxycholic acid. When you actually divide up PBC, what we've learned over time is that really there is a lot of heterogeneity. And we've only learned that from getting bigger and bigger cohorts. This is actually unpublished data from years ago when we just looked at our own Toronto experience of well over 500 patients. And you can see that there are essentially 3 patterns to the progress of PBC. The patients who responded, who didn't develop portal hypertension or liver failure, the patients who had a portal hypertensive phenotype, and that portal hypertensive phenotype is not particularly well picked up by alkaline phosphatase, and then the patients who progressed to more of a liver failure phenotype. So this adds to the challenges when we are thinking about who is the best patient to recruit to the next generation of trials that we hope to see for PBC. However, going back to our care pathway, we believe that ursodeoxycholic has an impact. I'll touch upon that in a second. We offer that to all of our patients at present. But to speak to something that Robert said, just because ursodeoxycholic acid is a relatively cheap drug does not mean that our patients should have the expectation that A, it's the only drug that will ever treat them, B, that should always be the first-line therapy for PBC, and C, that they couldn't enter clinical trials without using ursodeoxycholic acid. That would be a model of care which is not applied to any other disease in terms of drug discovery. So, Urso is a good drug, but it doesn't stop where we want to get for our patients. We then treat everybody, and then, as you'll hear a lot about, we use the tools that we've learned both for clinical trials, but for risk stratifications to try and identify who is at greatest risk. And again, one of the things we've learnt about risk stratification is that presently we treat our patients and we say that they have to fail therapy before they can access better therapies. Well, you know, to echo what Robert said, if you were a patient, that is an illogical way to treat a disease, to wait to fail. I mean, we all teach our children to succeed, so I don't see why PBC should be any different. Now, what about Urso and whether it works? I mean, this is a long, tortuous story. It defines everything that we're talking about here in terms of surrogates. This is the latest data that probably finally answers, at least to Bettina and myself and the global PBC study group, that ursodeoxycholic acid is associated with prolonged transplant-free survival. But this is data that has accumulated over 5,000 patients and 20 to 25 years worth of experience to really be able to show the difference. And of course, we are criticized for it being retrospective, not prospective, and uncontrolled. But there appears to be a benefit for everybody with a drug like ursodeoxycholic acid. So in a sense, although that never takes away the concerns about safety of drugs, that does lead us to suggest, for PBC at least, that the use of surrogates it has some utility and our patients can benefit earlier than waiting 25 years to prove it definitively. Nevertheless, if you follow a group of patients with PBC in the current era, you will see that despite the change in name, over 10 years, nearly 40% of our patients will be living with cirrhosis. We all agree that the development of cirrhosis is a significant event for a patient with chronic liver disease, and it comes with a development of significant morbidity and mortality. And therefore, our goal in treating our patients is the prevention of cirrhosis. We also recognize that, you know, we've learnt a lot from liver histology, because liver histology is the disease. And this is just an example of, because this study that we published with Thoern back in 2010 is actually using an endpoint that then became the evolution for the endpoint for the development of obeticholic acid. And this endpoint showed that in patients whose biochemistry does not improve, they have progression in the stage of their liver disease, for want of a better term. Their fibrosis progresses. So that is not the desirable situation we want for our patients. Now, to speak to the heterogeneity, you know, we all work in different environments. Our patient referral basis is often different. Some of us are mainly secondary care, some of us in tertiary care, some of us work in quaternary centres where we're attracting second and third opinions. But because of that, with all the collaboration amongst the academics, we recognise younger age at presentation, sex, specific nuclear antibodies, your stage at presentation, your liver stiffness, the degree of biliary injury are all factors that influence the outcome and influence the response to treatment, not just ursodeoxycholic acid, but I'm sure drugs going forward. We therefore worked very hard, and again, Bettina's going to show you in greater detail, to use the tools that we use to diagnose our patients, but to flip them round so that we could become aware of their risk. The goal of current therapy is to treat to risk, not to treat to stage. You know, if we wait to treat to late stage disease, we will never really impact the outcomes for our patients. We've flipped it round using these simple surrogates, alkaline phosphatase, bilirubin, and they are very, very powerful stratifiers of risk of future events. We've overcomplicated it, and so this is just an example of again, how we innovate at the same time as developing new drugs. We've got lots of risk models now which are very complicated, they're algorithmic, you know, we're even doing some machine learning, but actually we did this on the back of an envelope, and we've got one of our fellows to submit it to EASL. If you simply divide patients up by their age, whether their bilirubin is elevated and their alkaline phosphatase at baseline, and then you repeat that assessment at 1 year of UDCA. We're now using this in our clinic, a simple traffic light evaluation. And so we're trying to encourage that patients who start off red, and this is the question that Robert raised, you know, if you start off and you know you're already bad, why not just zoom straight ahead to the PBC specialty clinic? And then the model goes, if you're still at red and flashing amber at 1 year, despite Urso, and maybe that can be done at 6 months, you know, again, zoom forward to the PBC specialty clinic so that A, you can access new drugs, and B, you can access the trials, and C, we can actually recruit to the trials because they're getting harder and harder to recruit to. So we have to evolve our care pathways. So this then fits again into our care pathways. We look at the response to first-line therapy. We do this at 12 months only, actually, essentially, because that's what the literature is based on. We could actually do it at 6 months. It's pretty much the same. And again, we do on-treatment risk stratification so that we can think about second-line treatments. And those second-line treatments have evolved, and we now have license opportunities of obeticholic acid, which I'll touch upon and which you've already heard about, because it was innovative both in its mechanism of action and in its regulatory pathway. And then, of course, there is off-label therapies. And our goal is that whatever we learn from off-label therapies ultimately becomes licensed therapies. Because, again, our goals for the care of patients with PBC is uniformity of care. We want all patients with PBC to have the same access. And if we rely on, on off-label therapies, then ultimately you cannot develop uniform care pathways for patients. It's very, very difficult. The licensing process for drugs is to all of our patients' benefits in terms of efficacy, but of course safety. And that's a very important job that you guys do in terms of drug safety. So what about the POISE trial? It is worth reflecting. We now use this in standard of care. It's reimbursed in most countries, and therefore OCA is, whilst conditionally approved, is being used. It's a very simple study design, but I want to raise a number of points which have come up from your stakeholder document. The inclusion criteria was an alkaline phosphatase over 1.67, with or without an elevated bilirubin, but relatively early stage. And then there's a placebo-controlled trial. And then there's a primary endpoint at 12 months, which is a biochemical surrogate. So we don't need to rehearse all the limitations. We're going to hear all of those things. But I want you to look at Table 1, which is essentially the demographics. Because one of the challenges in developing new drugs for PBC and in your stakeholder document is what should the inclusion criteria be for the next generation of drugs? And if we were to follow the stakeholder document as it stands, and we only let patients in who had an elevated bilirubin and an alkaline phosphatase over 2, then suddenly a huge number of the patients who are at risk are not going to get in access to new drug therapy. And we can inverse this just by looking at who entered the clinical trial for POISE. Because I'll remind you that the average age of transplant, certainly in the UK for PBC, is 54, and that if you're diagnosed before the age of 50, you have a 50% chance of having an inadequate response to UDCA. And by using a very simple surrogate for our inclusion criteria, the average age at diagnosis in the POISE clinical trial was 47. So, although, this is not to say this is the best inclusion criteria, you can see that it does work and it does capture patients at risk. And there will be a significant risk that if we make the inclusion criteria too hard, so to speak, we raise the alkaline phosphatase and we push the bilirubin up, then a significant portion of patients will not even be able to access and will not potentially benefit from new drugs. You've seen already what was needed to cross the regulatory line by the FDA and by EMA. And, this is a step forward for our patients, but there's 50% of patients who don't get potentially enough benefit. They don't meet a dichotomous surrogate. But again, that then challenges us to what is the benefit. At the moment, we're using biochemistry. It's a very reasonable surrogate of efficacy. But actually, when you look at all of the patients who receive this new therapy, all of the patients in the treated arm do see an improvement in their alkaline phosphatase. So quite clearly, and again, to speak to the journey that we went through with ursodeoxycholic acid, there'll be patients who are deriving benefit at a smaller level, but over a longer duration, that benefit is very impactful for them. And so we do, as we go forward, need to factor in that our goal should be the development of new drugs that benefit the most people, not just the patients at whatever we define as the highest risk by some dichotomous approach. The other thing I think which is very difficult for any new drug, and this is again focusing on OCA but is relevant to all drugs, is that because we tend not to compare it against ursodeoxycholic acid, we may underestimate the actual benefit biologically of that drug. And so there is actually monotherapy data for OCA where you can see the impact on alkaline phosphatase is at least as good, if not better, than ursodeoxycholic acid. But clearly, because ursodeoxycholic acid is our standard of care, it's quite hard to demonstrate. And so we might also be underestimating the benefit of drugs. I think this is less of a challenge for PBC, where we've got, impactful therapies, but it's a very big and live issue that we'll no doubt talk about when it comes to primary sclerosing cholangitis. And that is the issue. Is potentially existing therapy actually hampering our ability to develop new drugs, particularly if that effective therapy is not very effective? pruritus you talked about, I think this speaks to a number of things. One is that none of us in this room expect our drugs to come without side effects, but it's a balance. It's a balance of understanding disease biology and what our patients want. But this is both something that our patients presently cope with, but it also speaks to why we need new drugs beyond obeticholic acid. We don't want the field of PBC to end just with one licensed therapy on top of UDCA. I mentioned off-label therapies. There's been a long history of the use of fibrates, particularly in Japan, particularly in France, and there's now a randomized controlled study. It's a small study. It's only 50 patients in the treatment arm versus 50 patients in the placebo arm, but clearly demonstrating some interesting results and potentially some benefit to patients using a different mechanism of action. So this again speaks to the need for new drugs, but it also talks to the challenges because this group used a different entry point for their clinical trial, and they have using the Paris criteria. So I just highlight this with the alkaline phosphatase. There are patients who entered the study with normal alkaline phosphatase because that was the slightly different inclusion criteria you could enter on the basis of alkaline phosphatase, bilirubin or AST. That's not necessarily a bad thing because there are patients still at need who've got relatively low alkaline phosphatase. But it is a challenging thing when we talk about comparing different therapies and trying to demonstrate that we've moved forward in our drug discovery process. And then to finish, and again to speak to something that Robert spoke to, clearly as physicians, our goal is that our patients live as long as possible. I always tell my patients that they want to outlive me and, still be there when they've retired. But, quality of life is as important as quantity of life, and we recognize that to be very important across all cholestatic liver disease. And we would like to get therapies that improve the quality of life. That is very challenging. For pruritus, you'll already be aware that there are companies developing very specific pruritus therapies based on biology. But if we were to impact on the more non-specific but nevertheless impactful symptoms such as fatigue and bone ache, that again therefore really does speak to the idea that the current paradigm of treat to fail will not be the way to improve a symptom complex. Because it's highly likely that for these complex symptom complexes, they are a complex reflection of cholestasis, and the sooner we develop drugs that impact on cholestasis and offer them to our patients as early as possible, the greater likelihood we are to not only make them live longer, but hopefully make our patients feel better. And I think that is the last slide.
Thank you very much for this very interesting presentation. We'll see if you have some short questions, but I wonder, do you see any other kinds of biomarkers or a role for elastography or anything in the future that we maybe can use?
So, PBC, we obviously that's one of the challenges, and, you talked about it actually about if you put too many diseases together. So actually for PBC, yes, I think that some of the markers like elastography do have a role. That doesn't mean if I say elastography works in PBC that it will necessarily work in primary sclerosing cholangitis. So that's why I think we should be distinct in our discussions. But PBC has a parenchymal response. It's essentially cholestasis and fibrosis, and you don't have large duct injury. So therefore, the elastography is more stable and not so influenced by bile duct obstruction. So in adequately powered studies, over sufficient duration, then elastography could be something that would help in terms of demonstrating benefit. That doesn't say that there isn't individual variation when you use elastography in clinic. Of course there is. But in a clinical trial setting where you can standardize the elastography measurements and set some standards for it, and where you can adequately power that study, then I think elastography would be of use. I think tests like ELF can also be used in patients with PBC. There are issues that, I've discovered that ELF is not universally licensed across the world. In terms of its applicability in different environments. But again, a study that's adequately powered and of sufficient duration, then those surrogates will, particularly for PBC, will be, I think, potentially very powerful. We haven't explored the role of MRI in PBC. It's too early to say.
Yeah. Thank you very much. Are there any other short questions for now? Then we move on to the next speaker, which is Bettina Hansen. that will talk about historical outcome parameters used in PBC and the search for potential. Please, Bettina.
Thank you. Thank you very much, and thank you for inviting me for today. I'm honored to be here, and I even have to give 2 talks today. I'm not sure they're up there. It's a bit slow. Okay. We're getting there. Okay. Thank you. So I'm actually situated next to Gideon every day. So he comes in at my office every morning. But I also visit Erasmus MC quite often. My talk is about this first one about endpoints, and just to recapitulate, the true endpoint, you have to meet the criteria recognized by academia and guidelines, and that means that it has to be relevant for the patient and directly measures how a patient feels, functions, and survives. So according to the reflection paper that we have all been given, the true endpoint here is defined as death, all cause, liver transplantation, decompensation of cirrhosis, and a MEL score of above or equal to 15. This, of course, is debatable. Hepatocellular carcinoma and Rotterdam severe disease stage might be also an opportunity to explore in this case. Especially the Rotterdam severe disease stage could maybe capture events earlier. What are the pros and cons if you look at a long-term outcome for PBC? The pros, of course, is that we do not have a potential bias there. We measure directly the benefit or harm. But the problem is it just takes very long, as we all know. The trial duration when you have to design such a trial will take about 8 to 15 years. And it requires large populations, and often the event that we are looking at could be very much confounded by competing risks. That also can have influence from other therapies that runs in between. If you're looking at a patient at that age stage, they might have other therapies for other diseases. And also, we do not in time capture symptom benefits. From an ethical perspective, I believe that this is very unacceptable. So that's why also everyone is looking right now at surrogate endpoints. How can we otherwise, in an earlier stage, capture the need and the response of a new therapy? And to be a surrogate endpoint, you have to have a validated substitute for the true endpoint, but that means that everything that we can otherwise observe at the true endpoint has to be captured in this true surrogate endpoint. The pros and the cons looking at surrogate endpoints is, of course, time and care. A new intervention is quicker available for the patient in need, but also the benefit and harm of an intervention is observed quicker. For the design of a new trial, it means also the sample size is less, the shorter duration of the study, and it also influences the recruitment and participation enthusiasm from the patient perspective. Furthermore, the endpoint in this case is not affected by crossover of therapies or subsequent therapies. Problems, of course, is that we have to measurements may be subject to bias. We need, again, validations. And the problem is also that we have various definition, cut points, combined endpoints, etc. And because you have a lot of new therapies, it depends, of course, on the mode of action of this intervention we're looking at. So just, again, looking at the Ocaliva trial, the POISE trial, the inclusion criteria for that trial is ALP above 1.67 and or abnormal bilirubin, and a bilirubin is, should say, 2 here, below upper limit of normal. And the response criteria is the ALP below 1.67, a 15% reduction compared to baseline and normal bilirubin. Comparing that with the bezafibrate trial that has just been published by the French group, the inclusion criteria there is non-responder according to Paris 1, normal bilirubin, normal ALP, normal AST, normal ALT, normal albumin, and normal PT. So there's a big diversion in when you look at the different two trials that are out there. It is now advocated in the paper that we have in front of us that the duration of a new study, of a new phase 3 trial, should be 1 to 2 years, adding preferably on the standard of care, the UDCA treatment, but not necessarily. The intermediate endpoint that we should look at is ALP below 1.5 and a 40% reduction compared to baseline and normal bilirubin. Just for you to be aware what that means, that is, if you have an ALP at baseline at 1.5, that means that at 1 year you should have an ALP less than 0.9. Or if you have an ALP equal to 2, that means the ALP should go down to 1.2. So it's very different. A 40% reduction is a lot more different than 15% reduction. Let's just go back at a time where in 2006, when all the response criteria that we have in front of us was created. First from Perez in Barcelona, on a number of patients of 192, he indeed looked at the ALP with 40% decrease. In Paris 1, they have an ALP below 3 times the upper limit of normal. The Rotterdam criteria does not include ALP, but Toronto does have an ALP below 1.67. The Paris 2 criteria is indeed a 1.5 times the upper limit of normal, but also including AST below 1.5 and a bilirubin below 1. And in the Japanese study, they are looking at gamma GT instead, with a normalization of gamma GT or 70% reductions. So all these biochemical response criteria were designed maybe not as a response criterion, but more in the relation to the outcome of survival and liver transplantation. And they're all, the number of patients you can see varies up to 375, and the lowest from 69 patients. Nowadays we have the UK PBC group and the global PBC group, and there are actually a lot more out there. There's a Japanese group as well, with combining all these data that we actually looked at the previous slides. The global PBC study group now hosts 600 PBC patients with more than 30,000 patient visits and more than 20 years of follow-up. The sites comes from not only Europe, but from North America, but now also from Asia. So from a rare disease, we have now 2 at least gigantic databases that I think we should really try to explore as much as possible. And indeed, within these databases, we can confirm that all the criteria that we were looking at before in Barcelona criteria, the Paris 1, Rotterdam, Paris 2, Toronto, and also the gamma GT of 70% reduction or normalization, they all work, and they're all very significant with respect to identifying patients who are doing worse or who are doing better. The best one is actually the Paris 1 criteria, as you can see here. So what makes a good surrogate endpoint? It should be frequently observed, hopefully assessed within a short time frame, easy to measure, non-invasive preferably, and at low costs. And it should have been demonstrated that this endpoint is linked to clinical outcomes. Preferably, we should also have multiple trials that also demonstrate that these surrogate endpoints works. And that's a little the problem in these settings of PBC, PSC. If we go down to specific bilirubin and alkaline phosphatase, bilirubin, as you've heard from Gideon, they are key diagnostic variable for liver deteriorations, and it's used in multiple prognostic models, also in the Mayo model, the MEL score, and the Child-Pugh score. Alkaline phosphatase is a key diagnostic variable as well, and used in all the components of the established criteria that we just showed. So can these be used as surrogate endpoints, and that was the thing that we explored in the first thing that we did with the global PBC study group, as you probably all know. And that's the plot that you see here on ALP normalization, that is below 1.67, and then compared with the groups normal bilirubin or abnormal bilirubin. The problem with such variables are that they are continuous. And that makes for a statistician, as me, very difficult sometimes, because what kind of thresholds do you actually use? Is it 1.67? Is it 1.5? Is it 2? I don't know sometimes. The magnitude of efficacy, should we look at the percentage differences actually, or should we just skip that one? And also, what time point should we look at? Is it 1 year or is it indeed 2 years? And I think it's very important that when you see that an ALP does go below 1.67, it should also be sustainable. It should not be a one-time blip. And finally, what is the impact of these true endpoints in the natural history of disease? Association and mechanism of action is important. So looking at ALP, the only thing that I could find out together with the whole team was that ALP actually lower is better. We did not find a true cut point. 1.67 is a nice cut point. 2 was sort of the optimal cut point that we could reach, but it's not significantly different than 1.67. For bilirubin, there's more sort of natural cut point. You can also see that on the blip here on the y-axis. We've got the hazard ratio for liver transplantation and death, and there's a sort of jump there at 1 where it really starts exploding. So there we could sort of find a natural cut point of 1. We actually did a more closer look when zooming in on ALP below 2 and also zooming in on bilirubin below 1. And when you look at it there very closely, you find that even below 1.67 of ALP, there is also a sort of trend going on. And if you go ALP below 1, there's not much to gain there. So again, concluding that ALP lower is better. For bilirubin, the ones that lies between 0.6 and 0.7 are going a little above that until 1 is already at higher risk, actually. So I'm not sure if whether 1 is that much the strict threshold that we should look at, because patient could really benefit from even going lower than 1. So on top of this, also at the same time, in 2014, 2015, there were a lot of risk scores that came on the market as well, you can say, where we're trying to identify the best possible way with all the parameters that we have at hand to find out who is at higher risk. So the UK PBC risk score was developed and the GLOBE score was developed, and at the same time we also had the APRI score, which was put on top of biochemical parameters. Looking at just zooming in on the GLOBE score, which we made with that, if you have a GLOBE score calculated, it's a very long formula. I'm not going to bore you with that. But if you calculate the GLOBE score and you look at the ones to 15 percentile or less, it does very well compared to a matched healthy population. That is the left plot. While looking at the right plot, the ones that goes above this 15 percentile, they do significantly worse than a matched population. And the C statistics, or the performance of these GLOBE score, is 0.82, which means that it's doing better than any of the response criteria that we previously have observed, which would have a C statistics of about 0.775. What was also important, as I said, that is that the prediction that you're using, or the response criteria that you are using, is not something that is strictly at 1 year. It should also work at 2 years. It should also work at 3 years, etc. So a dynamic risk score would be the best thing to have. Actually here, just to give you an example of a patient, you see that the GLOBE score is calculated here during the time period of 12 years, this patient is observed. And on the y-axis, we have the globe score. And you see that this patient has a clear, healthy-looking sort of globe score. They're going below the threshold. The patient is doing okay. But at a certain point, around 7 years, the globe score suddenly explodes, and the patient actually did not survive 11.5 years. So you could use this globe score also in a dynamic fashion, and it actually is proven that using it as a time-dependent covariate, it gives you a clear identification that these patients are doing worse over time. So not only at 1 year, but also during the phase of the patients. So just establishing the response criteria here, all these criteria here are listed here. You see a lot of them involves the alkaline phosphatase. Some of them have the AST. Only one of them actually are using the gamma GT. And the APRI, the UK, and the globe score are using the platelet counts. So how do we go further here? With this, keeping this in mind, and how do we work it from here? I think, do we need new response definitions? That's the question. The minimum requirements is, I think, for sure that any endpoint that we do choose should be a level 3 endpoint, a non-validated surrogate, yet one established to be responsibly likely to predict clinical benefit. Preferably, you would like to have a level 2. So the discussion could be, should we use the created path of ALP below 1.67, etc., with the normal bilirubin, or should we explore the ALP and bilirubin lower than 1 and ALP lower than 1.67? Of course, the mode of action or the intervention can lead to maybe we should look at gamma GT instead, or AST as a variable. Should we include the MEL score, the Mayo risk score, or any of the other, the ELF score I not even mention here? And I think maybe it's worth looking at what the additional compound of fibro test or fibro scans is on top of all the variables that, or all the response criteria that we have looked at. So in summary, I think it's important that we are all here today, because I think it's good to look back and see what have we learned from where we are. And I think it's important that we validate any new surrogate that may come. And I think it's important also to use the biomarkers in a dynamic model. And I think also include maybe the fibroscans and fibrotests to replace histology. And I think discussion points indeed, what should be the standard for alkaline phosphatase normalization? Is it 1, 1.5, 1.67? Whether we should use the percentage reductions. And one more thing that none of us has really looked at yet is, when do we stop treatment of these new compounds? When should new drugs be stopped if they do not work? Or when do you need to switch? Maybe that's the problem that we're going to face in the future. Okay, I think that was my end of my presentation.
Thanks, Bettina. Very instructive. Well, maybe only one question, if urgently needed. In the interest of time, I think we should proceed as soon as possible, but there's one question, of course.
Just one short question. Nikolai Naumo from Novartis. Bettina, is there enough data in the global PBC database to allow analysis evaluation of gamma GT as a surrogate endpoint to the same extent as alkaline phosphatase?
I can tell you that the gamma GT that we have available at baseline is for around 1,000 patients. So it's not for the 6,000 patients. We are going to do an update of the global PBC database, and there we'll for sure look at the gamma GT. Yeah.
Okay, then Bettina, please go on with your second presentation, potential trial designs and suitable study populations.
Yeah. I'm sorry I have to bore you again. So this is about, well, maybe I should just go back one slide, but this one is about the design of a study. But first I want to go back just a little. One of my second points of this one is also to look at the selection of the study population. I think that has very much to do with kind of endpoint you choose. It's very linked to each other. So where are we? We have patients on UDCA who becomes non-responder or responder depending on what kind of response criteria we are choosing. And that's, I think it's important to say what kind of response criteria do we use, and then it also totally links with what kind of patients do we include into the trials that we are looking at. So what we aim at is, of course, to identify these non-responders, to give them new therapy, and hopefully to see them respond as well and avoid any premature death or liver transplantation. This you have seen before. And I think, and like Gideon said, if we are going to include patients at a high risk for progression that is advocated here, indeed, they are in urgent need of a new treatment. I could not agree more. But if we are looking at, like suggested, a risk population after a minimum of 1 year of UDCA with ALP above 2, question mark, maybe I did not understand it correctly, but it says "and" in the paper, and the abnormal bilirubin. That means we are looking at the population that I have plotted here for your information. That's 8.9% of the patients with PBC. We are missing these two groups at least, I think, then. That are the patients with ALP above 2 or an abnormal bilirubin. So that's my question to EMA, maybe, that maybe I did not understand it correctly, or maybe it is indeed meant to look only at the highest risk group when we include patients for new studies. But I think we will then maybe have a problem also with getting patients into trials, and that's, I think, is something we have to discuss, I think. Is it also ethical acceptable? We should minimize bias and confounders for sure, but we should make sure that we have the numbers of subjects to enroll in a trial, and also because of the speed of enrollment, interpretation and extrapolation of this data. And of course it has to be accepted by you, but also by the physicians. When you look at the numbers at risk, and you could sort of split out the ALP instead of using 1.67, put in 2 instead. What is, I think, important, the blue line is the ones that are doing better than the rest. But the green, the patients with the green line, so ALP is above 1.67, and they do have a normal bilirubin, are doing significantly worse. And for sure, the patients with abnormal bilirubin, no matter what the ALP is also doing worse. ALP, as I said, lower is better. So I think that maybe below 2, we should also look at. Even for bilirubin, maybe you should also look at patients who are just above 0.7. That's maybe also something that could be discussed. Another way to look at it is maybe you could also use the Rotterdam disease stage, which is not looking at ALP, but looking at bilirubin and albumin. That was defined, it's a more sort of disease stage than anything else. The early PBC stages are the ones who are defined with normal bilirubin and normal albumin, so both normal. While the ones that have an abnormal either bilirubin or albumin, they develop more quicker and event as in death or liver transplantations. And if you have advanced disease with both of them are abnormal, that does not look good. You could also use the GLOBE score to look at who is going to be treated. If you have a patient with a GLOBE score above the age-specific threshold, actually these patients are potentially could benefit from additional therapies. So I think there is discussion here on the selection of high-risk populations. I think indeed the ones that are at high risk are in urgent need for sure, and the problem is just that it might be too late. Treatment might not be efficient enough in the high-risk group. And the other populations that are not at high risk need to wait too long before they can come into that group of high risk. Next to that, if we do include patients only in high-risk group, the further extrapolation to other groups are questionable. So that was my comments on the inclusion criteria to phase 3 trials. The next slides that I'm going to look at is something totally different, actually. It's more for a sort of new kind of idea that we are working on, and we've been working on for the last year. Because we have these huge data banks and are part, I think that's important that we try to use these data banks. Like Elmer said as well, we have a problem that we do not have, maybe with inclusion of placebo patients or patients only on UDCA, it's going to be difficult now with there are 2 drugs out there. So for new compounds, it's going to be very difficult to have a placebo arm in there. Everywhere in the world, we have to recycle. We have to reuse the knowledge and data that we have. I think that's a new thing we have to look more carefully into. And it's not only good for the environment, but it's also good for the patient. And I think we actually owe the patient to use as much information that we have already gathered. So I think the huge database that we have here now is good for rare diseases, and especially also when I look at children's diseases, this is a really important thing, especially rare diseases for children. We should really use these data banks. It might be retrospective data, but it's important to gain as much knowledge and gather out that we can get out of there as possible to understand the disease and to understand how to move forward. We can study outcomes and study biomarkers, and we can search for indeed potential surrogate endpoints. And we can especially use these data for design of new studies. We can do power analysis on these data, and we can do indeed looking at specific selection of patients, high risk, low risk, medium risks. I'm going to show you an example now also of how we probably also could use this as historical controls. I know it's not something that you like, but still I think you should have a look, because I think it might be a possibility to use in the future. And I think it's important that we try to recycle and reuse data in the best way. And it might not be the only way, it's something that we are working on. It's work in progress. The thing that we have now is that we have phase 2, also phase 3 arm studies with an active versus a control arm, in this case the UDCA. And we are looking at an intermediate endpoint. And therefore we need to know that we have to go a phase 4 confirmatory study, a 2-arm study, active versus control. That means, indeed, as I said before, a minimum study of 8 to 15 years of follow-up with 500 patients, probably event-driven, where the endpoint is liver transplantation, death, decompensation, and MELD above 14. And it might be difficult, especially for the new trials that are looking at PBC. So let's look just for once at a phase 2, phase 3 trial where we have continued long-term follow-up on both of these just continue the patients that are in the phase 2, continue the patients who are in phase 3 with a long-term follow-up and a long, they still get the drug. And let's look at the follow-up study of standard of care. If we would use such a matched control arm, taking a historical control arm or a prospective registry, there are pros and cons, absolutely, and we have to acknowledge what is the pros and the cons. The pros is that we can reuse the gained knowledge and data, we recycle that. We do have a reduction of study time to clinical endpoint, and I think it's important, not only maybe we can assess benefit quicker, but we are also available to discover whether there's any harm at a quicker. And that, I think, is also important. And the drug might be available for patients more quick. The problems, and I realize that very well, is selection bias, heterogeneity, and quality. So how would we overcome these things? Selection bias, we could use, and I'm going to show you some inclusion-exclusion criteria instead that are very stringent. We can use weights, that is a statistical tools. Statistics have not also been standing still. There are a lot of new ways to look at data, and one of them is inverse probability of treatment ways to stabilize differences. One thing we do have to work at is quality bias, and how do we minimize bias, and how do we install quality of these historical controls or prospective controls. This is an example, and the data that I have taken is from the global PBC study group data, and I've taken the Netherlands, the Dutch PBC group within that, who is fulfilling one of the following criteria. So I've taken the selection criteria actually used by the OCA trial, the POISE trial for the patient group of the Netherlands. And there, so taking the selection criteria of the phase 3 trial, ALP should be a 1.67. The bilirubin could be abnormal. The bilirubin, in this case, less than 2 times the upper limit of normal. And the patient should have at least 12 months of UDCA or untreated. Of all visits in the rest of the population, I then applied this selection criteria and took the first visit between all the 30,000 visits that I have. I especially chose patients who are diagnosed after 1990 to control for population differences, because we know, and we've also published on that, the patient diagnosed prior to 1990 are more severe patients, and they do not have the same dose of UDCA given. There's a treatment change also, how do you handle decompensation? So that's why one of the most important things to look at diagnosed after 1990. And the way that patients are listed for transplant could also differ before that. So we are only looking at a cohort diagnosed after 1990. So in total, as a first stage, we had 137 patients which would fulfill this inclusion criteria that we're looking at as a sort of phase 3 trial. With this, where the differences between the selection groups that I then made in the global PBC study group, excluding the center that I am looking at. And you see that there are indeed difference between the sex, the population, the age at the inclusion criteria. The treatment, UDCA, is more or less the same, not significant different, but the treatment duration is significant different. So indeed, if you would take a historical control and just match it against them, you will find significant differences, obviously. Also, if you look at all the values of bilirubin until the gamma GT, it does not look good. All of them, more or less, except for the bilirubin and ALP, because of the selection criteria, are significant differences. The GLOBE score is not significant different. Oh, it is, sorry, it's P 0.001. The gamma GT was not significant difference. what I then did is to calculate these weights, and I'm not going to bore you with the statistics on that, but you can sort of weight these cases and then weight each patient with a sort of, depending on whether one patient could count for 2, but it can also count for 0.8, depending on how it is regulated within that study. The weights are stabilized so that the sum of the number of patients included in the 2 arms are still the same. And then you then compare with the weights, you then compare again the phase 2 potential trial and the global selection trial. And you see that now with the weights on, these arms are totally not significant different. And the same accounts when you're looking at the lab values. So with this method, you can actually design a sort of mimic a randomized trial. And it has been used a lot of times before, comparing new studies, especially within the hepatitis B and hepatitis C field. These methods have been used a lot to look at for HCC occurrence, etc. And it is a tool that I think needs exploration. So with respect to the cons that we had, selection bias, I think it is possible to solve that with stringent inclusion-exclusion criteria matching the specific trial. We could overcome heterogeneity with the use of weights to stabilize differences. So the one thing that really I think is crucial is how do we ensure quality bias and minimize this. And there I think it's something that I personally, together with the Global PBC Study Group, are working hard on, is how do we improve the quality of these historical controls or prospective studies that we are setting up. We need to do site visits, and we actually have already starting that. The red cap data collection, so we have to have a sort of similar sort of data collection that the pharmaceutical industry have to also have. We have to tracking of who's entering the data, how to store the data. We already have in the prospective part of our data capture. Of course, you have to send out queries. We already always did this with the Global PBC Study Group, so that's not something new. Again, also for the second bullet or the fourth bullet point, the lab tests has to be provided with upper limit and lower limit of normal, because that is, of course, an issue. In a trials setting, you have one central lab, and in this case, we have multiple labs. And important is that you need a board of experts, I think, to reassess all clinical endpoints to make sure that it's captured exactly the same way than it's done in a trial setting. And I think maybe to also make sure that the quality is high and up-to-date, a prospective data collection in parallel with phase 3 trials running is also a solution to be careful to look into. So I think comments and discussion points, I think selection bias can be avoided. Heterogeneity with some fancy statistics is something that I think should be explored more. Quality control rules must be applied and standardized, especially that standardization is something we are working on. And I think we should also consider looking at prospective registry cohorts to run in parallel. This was my last comment slide. Thank you.
Thank you, Bettina, for this very, very clear presentation, and obviously the plea for historical control groups to be integrated. Certainly a topic that we should discuss further now. Of these 60 minutes originally planned, we have 40 minutes left, I think. So maybe we concentrate on the most important and potentially controversial things that come up from the presentations and from what has been addressed with regard to what is included in the current form of the reflection paper. I identify, of course, here the rather strict inclusion and response criteria that we have proposed here. Just to explain this a little bit, the bezafibrate trial has, of course, fueled this to some extent. Just refer to the endpoints used there and the phenomenon that in the end placebo response was 0, which makes, of course, a trial size then very easy with regards to achieving statistical significance. This was one of the reflections. The disadvantage, and you have to clearly point it out this here, is the reduction of the population in comparison to the whole available PBC population. And questions resulting thereof of the representativeness of the population, and whether extrapolation that is then needed can be done to a less severely affected population. This leaves many questions open. Of course, inclusion criteria, we have so many different response criteria for Urso therapy on the table that I think one of the aims should be to have one standardized proposal being put forward and try to somehow get potential applicants into a more standard way of defining the population and not have 5 different things on the table that you can choose off, and which would then increase the heterogeneity of the material that becomes available. So in order to start with the discussion, maybe there is other opinions, questions to the selection criteria that we have proposed. And of course, attached to this, and Bettina and Gideon have also touched this, how can additional scores stratifying risks be used in the selection of patients. So please come forward with questions, proposals, whatever there is too. Cyril.
Bettina, I never understood why a threshold of, for instance, 1.67 is as good as a certain reduction in terms of percentage. Every patient starts off in all the models with their own alkaline phosphatase. So why is there not a strong preference for a percentage reduction instead of a certain threshold?
I think it's one of the, I think, struggling things that everyone, as especially statisticians, are working on. Why is it the absolute value, or why is it the percentage value that is the best to measure things? I think my problem with percentage difference is you don't know where you come from. So when you actually calculate a percentage difference, you don't know, did you start hard, then you can also go lower. If you already are low, a percentage difference of 40% will never be reached. So if you already are low in a certain moment, it's very difficult to go much lower. And that's why I personally do not like percentages. And also in the trial design, when you're correcting for the start value, you lose power. So that's a statistical problem. And absolute values in that sense is more direct. It's not only something that I see with PBC. I actually have the same, when you're looking at hepatitis B or hepatitis C, looking at viral load, etc. People also like to do viral load decrease instead of looking at the pure viral load. And again, every time it comes out, that the viral load itself is much more predictive than the percentages.
But on the other hand, when you started with a baseline 1.8 times the upper limit of normal, it's much easier to attain a 1.67 or below than when you started with 2.5 times the upper limit of normal. So
I think, and that's the reason why in the POISE criteria they also included at least 15% reduction to make sure that those who are just on the border have to go an extra bit lower.
And for PBC, is it known what the individual variation is over time, the natural variation in your placebo group? Because that also decides whether you should, for instance, choose for a 15% or 40%. In PSC, that's very relevant. But do we know anything about the natural variability?
Yes, we do. Yeah, we also looked at that, and that's also published in the first papers of Lammers, indeed, when we're looking at percentage differences. As far as I can remember, that indeed around, it doesn't really matter whether it's 30 or it's 20 to 40% reduction, that there's no significant differences in that sense to sort of have a threshold on that.
But also what Cyril's commenting on is 2 points really. One is, so in the placebo response is very low in PBC. The ALK phos is a much more stable analyte. It's by no means perfect. It's got all the issues of surrogates, but as you pointed out from the BEZA data, and actually look at the POISE data, the placebo groups are pretty, the ALK phos change is, I think, less than 10%. But I think to your point, Cyril, it's why there has to be a compromise, because you're assuming the biology is linear. That isn't the case, because we don't fully, we accept that ALK phos is within the disease pathway. It relates to bile acids and bile acid biology, but we don't fully understand the association between alkaline phosphatase and disease. And therefore, that's why the data clearly shows, and in fact the data, as you'll show later on for ALK phos, there's a very large number of people who are still at risk at relatively low alkaline phosphatase elevations within PBC, and so that is our challenge. I mean, the only other point I just wanted to follow on, I think, my concern is, there are two issues, aren't you? You have an inclusion criteria and you have an endpoint. And clearly they're linked in study design. But if you take an inclusion criteria where everybody, and it does say and, has to have an elevated bilirubin, then as Bettina showed quite neatly, you're going to basically exclude 91% of the patients with PBC. And so and that will impact on the whole cycle of that drug, and that drug will only be given to patients with, that very, very tight inclusion criteria. So I think, certainly the word "and" is challenging rather than "or." It's clear from the data where you exactly put, whether it's 1.5, 1.72, then there's much more fluidity in the discussion, because we can see that really is a sort of, they're all about the same, aren't they? And it comes down to, is our goal, what is our goal? And I think our goal is that the maximum number of patients potentially can benefit from new therapies, and that we have a disease area where there is logic to developing new drugs. Because if there is no logic to developing the drugs because the inclusion criteria are too hard, then the disease area just stops. Because that's just the real world. And the other thing I think which is relevant is that as we've got better with risk stratification, our care pathways are better. So we genuinely hope, although it's not, it's taking time to filter through, our patients won't have been living with an alkaline phosphatase for many years before they get considered either for second-line therapy or for clinical trials. Because, of course, in the last few years, we're still catching up. We're still seeing patients who've been at risk for a long time because there was nothing else to offer. Whereas we hope that as we go forward, that won't happen. So again, if you have an inclusion criteria where it's and you have to have an elevated bilirubin, you really are going to disadvantage a lot of people. I take your point. You'll have a very neat and tidy study, but I don't know what it will mean to the majority of our patients.
Frank Tacke from Germany. I have a question regarding alkaline phosphatase to the two of you. I was struck by the data that obeticholic acid decreased alkaline phosphatate in PBC patient, but it actually increased alkaline phosphatate levels in NASH patients that were treated with obeticholic acid. And I think it was Novartis then who later provided an explanation that FXR induces alkaline phosphatase. So I wonder how you can use this biological surrogate if you actually disadvantage maybe a whole class of drugs that might have this as an effect that's not really related to the cholestasis itself.
It's a great question, but and it does come down to that particular class of agents and whether or not your FXR is predominantly working through the bowel or whether it's working through the liver or whether it's working through both. And, you know, Nikolai can comment, tropixvar is obviously a more gut-specific FXR, and then the concern would be a gut-specific FXR would induce bowel alkaline phosphatase. But I think in the Flint study for OCA, it's only a relatively small increase in alkaline phosphatase. And so broadly speaking, I don't think it's a huge issue within PBC. And the way you could flip it around, if anything, then it may be that we're underestimating the benefits of drugs in a cholestatic scenario. So, but more to your point and to the challenge of any stakeholder document, it's got to be relevant to the drug. And therefore, whoever takes forward any drug must understand their biology when they're designing their clinical trial. It's essential that you understand exactly how your drug works, because it may not be the same as how someone else's drug works.
Yeah, but if you really focus on alkaline phosphatase as an endpoint, of course you're running at risk that you might exclude some mechanisms of action that would not necessarily really reflect what's seen in the natural history.
I agree. So in terms of the simplicity of just using alkaline phosphatase, it works very well, but in clinical practice, and that speaks to the approach perhaps of the Paris group, we see people with relatively low alk phos who've got elevated ASTs or falling platelet counts, and we think those patients are at risk and have a biological process that is not positive. And we do worry at present because our payers say, well, you can only get the new drug if your alkaline phosphatase is elevated. That group of patients is missing out. And that, again, is a challenge to EMA in terms of how didactic do you wish to be in defining your inclusion criteria, because in a short document, it's quite hard to cover every different scenario. It does happen that if you use alkaline phosphatase and or bilirubin in PBC, that you capture the majority of the risk. It's pretty good because it's a biliary disease, but you're absolutely right, it doesn't capture all of the risk. And if you're developing therapies that are particularly antifibrotic and designed more for the portal hypertensive phenotype, then an alkaline phosphatase inclusion criteria may not be the correct one for that drug. And that is the challenge of trying to answer every question, as Elmer says, every question in advance when you don't know the question.
Yes. I think, Robert, you had a comment.
Thank you. So I'm going to take the traditional patient role and bringing more problems to the table than solutions. We have... I guess what Gideon said earlier in terms of the inclusion criteria, if we are to take bilirubin of 1 and above, data's already said that if you're above in your upper top quadrant of bilirubin, even with under ULN, we have an issue, we have a risk. And Gideon said, well, what does it mean for the patient? Well, what it means is a missed opportunity for life longevity. So I think that needs to be incorporated into the thinking. Another thing, I know that homogeny is good, but PBC isn't particularly homogeneous, and we need to look at the problem ahead of us instead of looking at the ideal scenario. Again, I'll look to the scientists to put this in a way, but patients with an alk phos of 600 don't respond to any of the medications that we know of, as well as patients who have an alk phos of 300. So we're looking at this stitching time saves 9. Without being too scientific about it. We have to address people that are earlier, and with the therapies that are coming to the table now, in terms of those who have still not responded, we're looking at a subset of a subset of a subset of a subset. And again, looking to the scientists for the data, we know that in terms of Urso response, partial response is better than no response in terms of life expectancy and everything else. So the inclusion criteria, I think it would benefit patients to be more open. And I think the actual response criteria, we need to be drug specific and we need to be patient specific. And I don't think it's realistic to look at one homogeneous set of results to indicate criteria, because if something works to a degree, it's going to be better than something that doesn't work at all. So we need to be really clear that where the lines are and that the lines are there to benefit patients and not necessarily benefit a nice little data box.
Yes, please go on.
Yes, I refer to that question that raised by Robert and also by Gideon. If you replace the and by the or, that means, of course, that you have kind of three groups in the end, right? So you have both alkaline phosphatase and bilirubin, or either of the two. So do you need to power it? Theoretically, of course, it's possible that any new drug works on either of the three groups, or both, or all three groups. So how is your sample size calculation to make sure that you do not have to do a new trial afterwards? Can you design a trial design that you include the three groups, and you do not have to redo it in a specific group if you find a post-hoc testing, or you have to re-go? Is my question clear?
Is that to me? Yeah.
That helps.
I think if you look at the POISE trial, they indeed do not have many patients with a bilirubin above 1. So most of the patients are with bilirubin below 1. So that, I think that was also one of the criticisms that they had, that they do not have enough patients at high risk. So I think you could stratify on that in this trial, any trial design. Yeah.
I think the question in the end comes down to the question whether patients having isolated bilirubin elevation or isolated ALP or a combination of those are biologically different. Is there any indication of this phenomenon?
That is a very difficult question, because I don't think it's biology. It is potentially disease duration and where they are in their natural history. Because we will recognise that our very late stage patients, their bilirubin will start to rise, their alkaline phosphatase may start to fall at the very end of the disease. But we know that at the very beginning that they were a patient who had a high alk phos with a normal bilirubin. So I'm not sure you can use that particular argument. I think the solution is, well, one, you can ask the statisticians, but it's also where I think we are headed is the concept that companies will need to do more, will need to do two studies. One is a study of high risk, however we define that. One will be a study potentially of advanced stage. And again, that's also quite hard to define, because it's no point doing too advanced stage. But, and that's where the opportunity then comes from a regulator to see the spectrum of impact across the risk and across the stage, recognizing that the study in the more advanced disease will be smaller. It will be harder to recruit, but will be very impactful for both efficacy and safety. But also that the efficacy signal may not be the same in the advanced stage as it is in the earlier stage, higher risk. So that's probably the best compromise that we have. But you're right, how you design it and how you stratify recruitment, and whether you have a cap and you say you only want to have at least, or a cap or a minimum 20% of patients with at least an elevated bilirubin, is certainly one solution, and it's quite a good solution, because I think from a sponsor perspective, they're also very keen to try and have patients across as many different scenarios, because that looks at efficacy but also looks at safety in different populations, which is important for our patients as well.
Yes, I agree that it's that the discussion is being highly specific in a small group, difficult to recruit, or a broader group. The risk of the first is that you end up with a drug which may have a limited effect because it's already advanced stage, and that's the next competition. So you block all future developments, perhaps. So I think in the long run, I think you're worse. So I really would think, because we will have the same later on during the day with PSC, and I think it will be also in the patient's perspective, if you limit yourself too much to advanced disease, then you completely block the future.
I agree totally, and that, all I'm saying is that, and I think that's what we're all reflecting on, that if you have a very tight inclusion with an and, bilirubin and ALK phos, I mean, we can discuss the ALK phos all day, whether it's the exact cutoff, but it's the concept, then we agree that you are essentially closing the door to future approaches. But what I'm saying is that, you know, to answer your question, one of the solutions is a sort of parallel track where we will have data on risk and we'll have data on stage, and we'll accept that the study size is different between different drugs.
Michael Trauner, Vienna. I have a question for Gideon regarding the portal hypertensive subphenotype. I mean, this is clearly also a group of high risk. And what about considering measuring portal pressure, either invasively? I would also be interested in the patient perspective, also non-invasively, spleen stiffness. I think we've been burned with portal hypertension in the field of NASH because here clearly alcohol is the confounder, which is less of an issue in PBC. Do you think we should consider that in study design also?
Look, I think for specific therapies that have a mechanism of action where it's believed that that mechanism will be more antifibrotic and therefore will benefit portal hypertension, then if someone wanted to go forward, and it would be a very difficult area to go into because of the impact is great, but the relative number of patients is small, then you're absolutely right. Some innovation would be required. And I would also definitely concur that there is a group of patients, relatively small, who currently are not best served by these particular criteria because often their biochemistry doesn't reflect what their platelet count does or their spleen size does. And we know that in any cholestatic liver disease, actually it's more prevalent, it's even more important in PSC that the event of a variceal bleed is a turning point in outcomes for patients. So they're at a risk. I think that there has been studies looking at portal pressures in PBC. There's a famous study originally done from Montreal. They actually did transhepatic portal pressures. It's quite invasive, but it was very insightful, and they were able to show that there is clearly prognosis. I think if you were to do portal pressure studies the traditional way, transjugular, beyond the challenge of standardizing that in clinical trials, which has proved to be a headache in NASH, of course in PBC you then chuck in the confounder of pre-sinus disorder portal hypertension. You're right, if you were to go down that path for those specific therapies, we should be looking at other surrogates to try and get a more realistic real-world answer to a small but important population.
The reason why I asked was also that, you know, FXR ligand have a direct mechanistic impact on that, and surely, I mean, probably non-invasively also addressing the issue of sinusoidal or pre-sinusoidal hypertension would be the way to go. But just as a reflection of thought, I mean, the patient acceptance, in my experience, for some reason, a transjugular procedure has far more higher acceptance than, for example, a percutaneous liver biopsy. Is that discussed among patients?
Yes, it is, in the short answer. I think when you look at the patient journey in terms of non-response, you know, you have PBC, it's incurable. Oh, we have Urso. Hey, the Urso's not working. Oh, we have Oka. Hey, the Oka's not. Oh, and so the hope is as big an issue as the science and the illness itself. And when it comes to end-stage disease and the risks that come with it, the patients are very much informed. They talk to each other. There are fora out there where we can have informed discussions. And the bottom line, the patient wants what's best for the patient. And if that is the interjugular, then so be it. And it's very much about informing themselves and accepting that's part of their journey. So yes.
Okay, in the remaining 15 minutes that we have for discussion, I would propose that we have two topics to discuss. The one is the confirmatory endpoints part, whatever that is, and maybe monotherapy alternatives, whether this is something to consider. Now, confirmatory endpoints, Bettina has quite frequently gone into the discussion of this. I think we have always, at least in the other two diseases that we have to discuss today, always made clear that part of a confirmatory endpoint is also not only the decompensation events and liver transplantation and death, but also the manifestation of cirrhosis itself. Maybe it's not 5 to 10 years or even longer that we would need to confirm this, but maybe relevantly shorter, because cirrhosis itself may manifest quite earlier than any of the events that are coming up as a consequence of this. Nevertheless, the big discussion that you have raised is a adjusted, or whatever you call it, natural history control, is it better than, let's say, the secondary endpoints relying on the non-invasive serological and imaging modalities that would support the primary evaluation based on ALP and bilirubin normalization? So the big question, is this model that you have proposed here, how can you make the point for its validity? The current position of the paper is, of course, we would not like this very much, but in the end, you know, the question is how to convince this.
That it's a difficult question with respect to whether we can find the fibroscans, etc., to prove whether there is cirrhosis, yes or no, in a timely manner, and whether that would be better. I don't have the data for that right now. We are collecting that prospectively, actually, in registry studies, because fibroscans are now used on patients in daily practice, at least in most of the hospitals that we are having data from. So that's every half year that they get a fibroscan. So that might solve one of the problems there. I think that we could indeed also see whether there is an increase in the historical or prospective registry data on that. In parallel, we are also looking at the biopsy data that we do have from the global PBC study group data, and matching them with FIB4 and APRI score to see whether there is a good correlation of that and what the impact is on the survival. So that is something we are actually finishing a manuscript on right now. FIB4 and APRI score are good, they are, but I think there must be better tools than looking at that. If you look at biochemistry values to sort of identify whether there is a cirrhosis, yes or no. I agree with you. In the best world, there is a placebo arm. Absolutely. I mean, I'm a statistician. I couldn't agree more with you that you need to have the best sort of proof for a new drug. Absolutely. I was just trying to sort of get how do we get further in a situation where we are with PBC or PSC or NASH, or with rare diseases in children, where it's such a rare thing. You have to be creative to sort of get further, and to get. I think that these rare diseases, they really deserve to get so much attention than any common diseases, and in that way you can sort of speed that up. And it's absolutely something that you need to work together with you or with FDA to see how can you improve that setting, or how do you improve that kind of tool, if at all possible. And I hope, honestly, I think what would be a good solution is if the POISE is confirmed in their phase 4 trial. Let's just assume that that is so, that control arm that you get out of there could be reused. That would be really nice, because that is a sort of data that has been collected in a clinical trial setting, and then you could sort of confirm that next to a historical control, so whether that the quality is good or bad. That would be a sort of proof of concept. So that is something to wait for. And I think it also could maybe, if we can use, I think pharmaceutical industry are very open nowadays to share their placebo arms. I think that is something that should be discussed with them.
Okay, thank you. I'm Peter Mol. I'm from the Dutch Medicines Evaluation Board, but on top of that, I'm also chairing the task force on registries that we have here at the EMA. And I wanted to pick up on your suggestion, obviously, on the natural history cohort, because as regulators, we are obviously interested in also new forms of data generation. We do see all the problems with this kind of data in terms of quality of the data set. We also see, obviously, all the issues when you do not have a placebo control. We do know there are examples to address that by doing prospective and even controlled studies based on a registry data. Obviously, you still need to measure the information. And I was wondering already when we had the presentation on the Ocaliva, the registration, the initial trial using the surrogate, and then the long-term placebo-controlled study, which I was wondering, well, how is it recruiting? I didn't hear you talk about that, because I would be interested in seeing, will we get those data? Because that's obviously the first question. The second one is then when we had the intervention here from my right-hand side, where the alkaline phosphatase is not always the best measure, because some drugs affect it in a different way. And we see that actually, I'm more familiar with kidney disease, and we have the same there with the creatinine that is affected sometimes differently by some drugs, and that is a good thing if it first goes down and then comes up again. So I was wondering, yeah, you may need to have that control or that controlled study on the longer term outcomes still for those drugs that have a different mechanism of action. So perhaps making all these remarks means that, okay, how well can your natural history cohort address these kind of aspects? Could you do prospective types of studies in there? But, well, how do you then still cope with the placebo that you may want to need, or an other control if you are getting other drugs at that time?
Maybe I may comment on that. For PSC, this is much more prominent question as for PBC because of the heterogeneity of the disease. So if you want to compare your open label extension trial with a virtual control group, it's pertinent in PSC that you collect a very rigidly prospectively virtual control group. But there is one issue that also applies to PBC if you want to do this, and that is costs. Because I've been discussing this with FDA officials from the biomarker development group several times, and they insist on having those data and the material and the lab data collected and stored in a certified fashion. Certified biobanks, freezers, which is very costly business, and we should discuss that and team up with all stakeholders to address that problem, and that will apply also to PBC.
Yes, I think your question was arguments to support the natural histories of diseases. I would like to reiterate on two arguments. I think for pediatrics, the risk of not doing that and the risk of asking for a placebo group really limits sometimes the inclusion of patients in studies. Because parents, and we have seen it now with an ongoing trial, they resist if they have the risk of a third or 50% that their child will get a placebo, which may concur with the deterioration of the condition. So that's actually, it's a major risk. For example, in PFIC, we are now dealing with that you may have a selection even in your patients studied. So that I think it's one of the downsides of just asking for placebo, particularly in very rare diseases. Second point is, and that brings back to Van Takker's comments, if you close the door for future developments, and you only ask for the standard of care, which may have a different, may actually act on a different disease group or a different phenotype of the disease, particularly if it's a heterogeneous disease, you will never be able to show the benefit of an alternatively working drug. But you can work on this, you can do the control if you have the historic cohort and see that even this other drug, or this new drug, may not be better than the existing drug that has been registered, but may deal with a better benefit for a different disease phenotype, disease group. And that's also the benefit, at least the theoretical benefit, of a historical control group. So I think these are two arguments that should be weighed in, apart from the real world, but certainly also in diseases which are very rare, to weigh in for the design of the trials.
This is Piotr Krzeski, MedBase Poland. A question building on this point is whether consideration was given to non-inferiority designs in this context, whether our understanding of natural history is sufficient to allow for margins, evaluations, and so on, to consider non-inferiority designs at a later stage of drug development at all?
I'm not aware of whether that has been considered at present, no.
Non-inferiority would apply to an alternative first line?
No, I was thinking ahead. Once we have, there was a lot of points made about the future and potentially the paths being closed for new entrants onto the market once the current treatments are approved and start to be the standard of care. Whether at this time we could start thinking about non-inferiority designs and using the standard of care and the new treatments, and whether our understanding allows for that.
Well, to my understanding, if you have of course, if you have an alternative to an established second-line treatment, I think that's the scenario you're talking about. From a theoretical perspective, non-inferiority is one possibility to demonstrate at least a similar positive risk-benefit that the established drug has. But from the statistical point of view, of course, this opens then quite a long list of difficulties that you have to address, which starts, of course, with the sample size that might increase, not to speak of, how to determine the non-inferiority margin that is acceptable and all these kind of questions. We're currently not in a position to define all these. Mm-hmm. Because nobody has ever tried to undertake such a kind of thing. Nevertheless, of course, this is a potential pathway that is open to developers. Usually in a situation where it is difficult to have placebo control, a non-inferiority to an established treatment is a pathway forward. Maybe because we're coming to the end of the time that is allocated to this question, talking about non-inferiority might lead us to the question that we have raised. Is an alternative to Urso on the agenda, actually? I mean, it has been displayed here that the response rate to Urso is only about 50%. Depending on the criteria that you apply, whether it's Toronto, Paris, or whatever town on the world, but it is not perfect, and therefore there might be enough room to improve the response rate. And for Ocaliva, it was already indicated that if it had been properly done, maybe they could even have shown superiority. And this is the second question attached to this: is superiority to Urso something to aim at for an alternative first line?
I'll just quickly comment, but that would be the ideal world. It's just a very difficult practical question for those people who recruit to studies and look after patients. because it transcends beyond your role into how much drugs cost. And so Urso is a good drug for patients with PBC and has demonstrated, actually, it's proven that surrogates do work, and the number of patients being transplanted for PBC has fallen because Urso works. You don't see that for patients with PSC because Urso doesn't work, but it's taken a long time. But, you know, clearly, if you think about the disease as a whole, it's more than just your blood tests, it's how you feel and how long you live. And Urso doesn't tackle all of that. And there may well be drugs in the future that could be superior to Urso. The question is, can we find a way to navigate that for drug discovery that is realistic? Because for the monotherapy study for OC, it was very, very hard to find the patients because they get started on Urso immediately, which is quite reasonable, it's standard of care, and also that's what ethics and the regulators were telling people to do. But I do think that it's important to word any stakeholder document to say that there should be the potential for a sponsor to come and say, actually, I think my drug is superior to Urso. I would like to target in a careful way it as first-line treatment. It would be the sponsor's problem to work out how they delivered that study. It wouldn't be the regulator side of things, but that is important, I think, for patients. I don't know whether that's realistic, but it may happen when suddenly we have very, very potent drugs. Then it may change, and then the pace will suddenly speed up because the drugs are so potent, the effect is seen so quickly that patients will be prepared to say, actually, I'll go for that.
But Gideon, doesn't it come down to the ethical question? If you have a patient who doesn't respond to Urso according to all the criteria we have now, is it fair to say, okay, you can deprive this patient of Urso because it does do so little that we might as well stop it and put him in a new trial? Or should you say, maybe it does do a little and we shouldn't deprive this patient of standard of care?
Well, and that is the big issue, is where do you draw the line as to risk and benefit, and how much benefit is necessary to go forward. The global PBC study data suggests that everyone benefits a little bit from Urso, but clearly there are some who benefit a lot more than others. And so I think what you need to do is present the biology as to why your therapy is so good, and to have a study design that then says, okay, so you're not going to have Urso, but there's an escape clause. And that's where the regulator will come in. They'll say, if after 6 months of this whatever, maybe 6 months, 3 months, 9 months, I don't know how long it is, you're not seeing the biological effect that is predicted to be superior, then you just go back to standard of care, whatever standard of care at the time.
But then you end up with the big question of the sensitivity of your surrogate. Is it already picking up a signal, yes or no?
Exactly, but you can get to some degree, you could quantify how much a patient loses by delaying their Urso by 6 months, and you could show that loss is insignificant.
Even in a primary non-responder?
Sorry?
Even in a primary non-responder to Urso?
In the global,
can you quantify that?
Well, if you look at, Bettina's been doing. Urso benefits everybody. It comes to this point that it's not dichotomous. Benefit is not dichotomous. It doesn't just go above and beneath 1.67. Just like other drugs may be benefiting everyone, it's just whether you can measure it or not. So I think it comes down to just demonstrating that it's acceptable to not give Urso for a certain amount of time while you try something else.
Excuse me, we have 2 people that have raised their hands, and it's you and then Robert, and then Elmer will...
I would like to come back to the issue of choosing between placebo control and historical controls. For autoimmune hepatitis, I'm a pediatric gastroenterologist, and even in pediatrics, I think placebo is a better choice for a relatively common disease like autoimmune hepatitis and NASH. But historical controls are valuable. Still, there are 2 meanings of historical controls. For rare disorders, we can collect data 20 years back, and these are real historical controls. But for me, more value we can get if we prospectively study those patients and we compare surrogate markers versus natural cause of the disease. But the major issue is the choice of surrogate markers we want to study, and of course finding money, because historical controls, even those studied prospectively, will be used by most of the companies. So they will not share money to support this kind of research. So the source of money for studying such controls is really difficult at the moment, I think.
Okay. Well, one more voice to hear, but I think we should stop the discussion after this. At this point, we have already run over a little bit, and of course we could discuss PBC and all of the problems that we talked today for a whole day. Nevertheless, in the interest of the other diseases that are coming, we should stick to our schedule, and I encourage everybody who has not had the word here, please go on and send in written comments on the reflection paper. So last word to you.
Okay, thank you, chairs. So very quickly to answer Henk-Jan's question in terms of the ethics, I think the ethical decision is to give the patient informed choice. In terms of the placebo, the first principle is to do no harm, and I don't know how I could tell a patient community that to have them on a placebo for a 2-year trial is to do them no harm. So I don't know how I face that off. So that's my last point. Thank you.
Thank you. So we close at this point. We have heard perspectives from academia and from patients. We have received quite clear messages with regard to the current proposal in the reflection paper, and we'll certainly take this into account. And I thank all the contributors here, the presenters, and all those that have contributed to this lively discussion.